Frida. Alright.
Good morning.
Good morning.
I'm Praveen and I'm Jonas. Good morning.
Morning. Morning. Morning.
Morning.
Felix. Good morning. So today we will take you through bubble Cpap system. So our training structure today will be introduction by bubble Cpap system, and then we run through other sections, assembly of the device, disassembly of the device, monitoring of the device, and then give you some other scenarios. Then from there we do practicals, hand-on sessions. We do hand-on sessions. Then after that we close with the bio-respiratory bundle up, or bio resources, the other resources that we use to do training with. Okay. So I heard that the session will go up to 12. So if we go fast, then we can go after 12. If we do it the way we do it, we may go up past 12. Yeah. So Bio Global Health is an innovation company and also a foundation. We do innovations around devices. So those devices are mostly for supporting the breeding for babies ecosystem. So at Bio, we are not just device companies. We do training as we are doing today. We do research, and we have a number of researches we have done across the world. In Africa, we have peer-reviewed researches that have been published from Tanzania, Kenya, Uganda, and Ukraine, and Belgium. So we have quite a number of researches, peer-reviewed researches that we have published. And then we do mentorship. What that means is, even after this training, this is one of the mentorship sections, but after this training, we can also conduct other cascade trainings. And we can follow up with you. If you have any questions, you can always contact me, you can contact Ken, you can contact our technical team. So all these people will help you so that you are able to use the device properly. So a number of resources that come with the training include bio-respiratory bundle app that you can use to supplement your training and when you are training babies. So currently we are focused on two devices. On your left is the bubble Cpap system, and this is what we shall be doing today. On your right is the oxygen blender system. Today we will not do oxygen blender system because we are only doing today the bubble Cpap system. So as I mentioned, training, we have divided training into different parts. So there is an online training, which we consider a foundation training. So that training is available online. You can do it at your own pace. If you have not done it right now, anytime, you can always go online, do it. It's a 2-hour training, and it will help you with a lot of knowledge. So you will be able to understand a lot about the bio devices. So after the online training, we organize for either virtual training or in-person training. Today we are doing in-person training. So some groups will be virtual training, but for your group today, it is an in-person training. So during the in-person training, we'll take you through all the sessions, and then we do the hand-on practice. So this is the training we do at Bio. So mentorship, of course, as I have mentioned. So after the training, we'll always follow up. We'll always follow up you so that we can understand how you are going about treating babies. Because training and mentorship are key in treating babies. Okay? There's no implementation, there's no successful implementation without training. So all healthcare workers should be trained properly so that they are able to use the devices properly. So we do training, we do mentorships, we do cascade training, and if there is anything else that we cannot offer in training, in mentorship training, in cascade training, you can always feel free to contact us even individually, or even you can even contact our technical team. Send them an email, they will be able to respond to you. So mentorship is a very important part in implementation of programs. So as I mentioned, we have quite a number of peer-reviewed articles that have been published in so many journals across the world: India, Tanzania, Kenya, Philippines, Belgium, and Brazil. So Bio also comes with resources. Okay? So, and Breathing for Babies, one of the Breathing for Babies resources we have is the Bio Respiratory System app. So this you can download from Apple Store or from Google Play, or you can even scan it. If you scan now, you should be able to download it in your computer. So it has quite a number of resources that will help you when you are doing training or when you are treating babies. So another important resource that comes with Breathing for Babies ecosystem is Bio-Neonatal Respiratory Distress Management. So what does this mean? It means it's not treating babies alone using these devices. It is looking at the baby as a whole. Okay? So you know very well when you are treating babies, they have other issues. It's not a respiratory problem only. Okay? So you can check if they have sepsis, give them antibiotics. If they have low body temperature, hypothermia, okay? You treat them, treat hypothermia. It's not just the device alone, it's everything else you do for the baby for them to survive. So these are one of the most important resources that comes with our trainings. So we'll look at this in details later on during the training. So as I mentioned already, we'll take you through the bubble Cpap system only for today. Okay. And we'll take you, we have already done introduction. We do walk through assembly, monitoring, disassembly, reprocessing, and hands-on activity. So the whole thing will be a classroom lecture and hands-on practice. Any question after that? So we'll go through the introduction to the bubble Cpap system. So can anyone tell me what they understand about this? About just bubble Cpap system? What does it mean? What is bubble BCPAP? So, bubble Cpap, BCPAP, is bubble continuous positive airway pressure. So, this is a form of non-invasive mechanical ventilation. So, the aim of this non-invasive mechanical ventilation is to provide pressure, flow, oxygen, and humidification. So all this is to meet the inspiratory demands of the baby. So you give pressure, you give oxygen, you give humidification. So all this is to meet the inspiratory demands of the baby. And so the main aim is to maintain alveolar recruitment and prevent alveolar collapse. Prevent airway collapse and maintains alveolar recruitment and open the alveoli so that there is oxygenation that is going on to meet the inspiratory demands of the baby. So this diagram is just to tell you what I've just told you, so that when oxygen comes in, oxygen is blended, then it is humidified, and then goes to the baby. The baby breathes out, so that mechanism of baby breathing out, the baby is breathing against a column of water. So when the baby is breathing against a column of water, it creates pressure, and it is that pressure that helps to open the collapsed lung or the collapsed alveoli. So in that way, you are able to meet the inspiratory demands of the baby. Are we together? So it has two parts: inspiratory flow and expiratory flow. You have used Cpap before, right? Have you used Cpap before? So what are the indications for putting a baby on Cpap? RDS. Yes. RDS. What is RDS? It's respiratory distress syndrome. Very good. So RDS is one of the most important indications for putting a baby on Cpap. A baby is delivered, the lungs are not maturing now, there is no enough surfactant, so the lung collapse. When the lungs are collapsing, you need a pressure to open the collapsed alveoli. So that is the respiratory distress syndrome. What are the indications? Yeah, apnea of prematurity. So apnea of prematurity is the baby stopping breathing for more than 20 seconds with decreased pulse. So you need to support them so that they breathe spontaneously. So you need to give pressure, you need to stimulate them so that they are able to breathe spontaneously to survive. Yeah, apnea of prematurity, one of the most important indications for the use of bubble Cpap. Any other indication? Yeah, we have mentioned RDS, apnea of prematurity, meconium aspiration syndrome. Meconium aspiration syndrome is one of the indications for the use of Cpap. Transient and kidney of the newborn. Pneumonia. Bus asphyxia, pulse activation, respiratory support, and prophylaxis for very preterm neonates. So you know very well that babies who are delivered less than 32 weeks, they should not wait to develop respiratory distress. Okay. It is recommended that babies delivered less than 32 weeks should be started on Cpap. Even in older babies, infants. So, infants with severe pneumonia, infants with bronchiolitis, infants with congestive heart failure. So these babies can benefit from Cpap therapy. Even some babies with acute asthmatic attack, you have used all the drugs to treat acute asthmatic attack, and there's no improvement. So in some settings, we can use Cpap to support them. So I'll play this video, observe what is going on in this video, and then you tell me what you have observed, okay? What have you seen? Should I play it again? What have you seen? Which part of the chest? Lower chest injury. Any other? Cranking. And here, cranking. Spiritual cranking. Use of accessory muscles. Which muscle have you seen being used? Abdominal muscles. Any other thing? Fast breathing. Any other thing? Okay, good. Yeah, you have mentioned all that, granting, seesaw ingrowing, sequoia retractions. That's the same baby. That is the same baby after putting on Cpap. Have you noticed any changes? Yeah. You can see this. There's no granting, there's no use of accessory muscles, and the clinical condition has improved. What do you see in the video? Should I play it? you seen going on in the video?
The circulation are low.
Yeah. Oxygen saturations are low. Okay, what else? What did you want to say? Huh? Oh, there's no chest rise. The baby is not actually breathing. So, low oxygen saturations. You can still see low oxygen saturation, 65%. SpO2 of 65%. The baby is not breathing. So, this is the same baby that has apnea of prematurity. So, let's start this baby on Cpap. What have you noticed? Huh? You can see the baby is moving and is breathing. What else? Yeah, oxygen saturations are increased. So this is one of the indications for the use of Cpap. So apnea of prematurity, baby is not breathing, low saturations, and probably bradycardia. We start on Cpap, then the baby starts breathing, and the oxygen saturations go up. So this apnea of prematurity is one of the most important indications for the use of Cpap. So what are the contraindications for not using Cpap? Or when do you not use Cpap? What are some of the contraindications? When you get those things, you don't put them on Cpap. Anyone with an idea? So this is a situation when you have to weigh the risks and the benefits for using powered Cpap or for using Cpap. So when you get conditions like this, you have to evaluate the baby. Pause and re-evaluate. And then ask yourself, if I use Cpap, is the baby going to benefit from the use of Cpap? A baby that has respiratory distress. If I use Cpap on this baby, and the baby has one of these conditions, is the baby going to benefit or not? If you see the risks outweigh the benefits, don't use Cpap. So these are some of the contraindications when you need to reevaluate your baby. Infants with or babies with upper airway problems, they are bleeding from the nose. Babies with trachea and palate. Babies with coronary atresia. Babies with foreign bodies. So babies with edema everywhere. You have airway edema. You have facial edema. So these are some of the upper airway problems when you need to reevaluate your baby and see if the risk of using Cpap is higher, stop. If the risk is less, they can still benefit from Cpap. If the risk is high, don't use Cpap. Babies with low airway pressure problems, like tracheoesophageal atresia. So in this case, the trachea and the esophagus are complicated. You know, Cpap is putting air. The air is going to the lungs. Some of it is also going to the stomach. So if there is a communication between the esophagus and trachea, you may not use CPAP. Pneumothorax, air in the lungs. So you know that some air is going to the lung, some air is going to the stomach. And you know, if there's pneumothorax, the air is already full of, the lungs are already full of air. So you may not use CPAP. Abdominal problems, severe vomiting, diaphragmatic hernia, and gastroschisis. So always follow the guidelines that are available for the use of our CPAP in your hospitals. But we recommend babies with such conditions, we evaluate always before starting CPAP. So these are some of the contraindications for use of CPAP. Any question after that? Yes. Does anyone know what is gastroschisis? So abdominal wall problems. There's fallacy and gastroschisis. So actually the bowel is coming out and the bowel is outside the abdomen. So there are two types, gastroschisis and fallacy. So you know that when CPAP therapy, some air is going to the stomach. And if the bowel is outside, it will compromise the bowel. So the bowel may have bowel perforation because the bowel is already compromised. It's outside the abdominal cavity. So those are two conditions, gastroschisis and fallacy. So we recommend you evaluate the baby before starting on CPAP. So that means you may need to treat gastroschisis, but it takes time to treat gastroschisis. You may need a surgeon to do some procedures. So it takes time. But if you think the baby has a acute respiratory problem and may benefit from CPAP, I mean, the baby is dying because of acute respiratory problem. So you may think about using CPAP. We know they have gastroschisis. Maybe severity of gastroschisis or severity of the fallacy. We look at those things. Because acute respiratory problem will kill the baby now before they die of gastroschisis. And that's why we say always reevaluate and look at the problem, the gravity of the problem, how severe is the problem. So if the risks outweigh the benefits, stop it. If the benefits outweigh the risks, use CPAP. Another question? So that was the introduction to bowel CPAP.
You guys look sleepy. Is it a night shift team? Or we are just bored?
So my colleague Kent will take over and take you through, walk through the bio balance. This is the most fun part. Sitting down.
Yeah, so no more sleepy night. So I was told that a couple of you might have tried the device on operation, weren't very successful, and then you took back into the store. Said this thing doesn't work. Yeah? So we're going to try and solve that issue. I'm going to walk you through the device. So by the end of the device, you know the different parts of the device, how the connections run, what what is needed for it to work. And yeah, so that's the first thing. Okay. So let's go ahead and start. Yeah. So feel free to ask questions. Feel free to object to what we are suggesting. And hopefully this is going to be fun. Okay. So as Chola rightfully said, is that the bubble Cpap system, like most of the bubble Cpap systems, which system do you use currently? Do you have any bubble Cpap systems that you use? Which one? That's bubble Cpap. Doesn't have a name. Umwani, the America, Fisher, Parker. Yeah? So please call ours by, don't call it bubble Cpap. Okay? Don't jump into the others, yeah? Yeah, so generally bubble Cpaps do functions. The functions of bubble Cpap are same across board, yeah? So there's Pumwani, there's the America, there's Fisher. They work almost using the same mechanisms. The only difference you're going to see in this one is that you don't require electricity. In the other devices, most of the time you require electricity. So this is the first device that is coming to market. It's able to blend without the functionality of electricity. But it will provide the general four major aspects of bubble Cpap. So there's going to be flow. You're going to see how that works. There's going to be oxygen supplementation because a neonate who needs Cpap most of the times needs some kind of oxygen support. And then there's going to be pressures and humidification. Okay? So our system is a linear system. And when we talk about a linear system, it means that the gases flow in one direction. There's no flow that goes backwards, okay? So what will happen if you can follow the arrow carefully, you see how the gases are going to flow. So just follow the arrow. Okay. It's going to repeat again. So it's coming from an oxygen source. So it comes from an oxygen source. We're going to look at the oxygen source. It comes to this big object, which is called the blender system. Then it goes to the filter, this. Then it goes for humidification, goes to the patient for experimental results. The patient expires, then valve regulation of pressure. Yeah? Yeah. So what do you need in terms of source? So the most important thing is the system is driven by the oxygen source. So that's why you don't have electricity. The lack of electricity means that A, you don't need medically compressed air. Okay? You can use oxygen, but the oxygen source needs to be of high pressures. Okay? So I'm not so sure which of these you use frequently in your units. So do you have more sources in your units? You have more sources. You guys are high up, yeah? And we have the oxygen cylinder that we're going to use. Do you have concentrators? Okay. So the wall source and the oxygen cylinders work best. Okay? Because for this system to function well, it needs a pressure of 50 psi and above. At those pressures, it functions best. Most of the concentrators have lower PSIs. So most concentrators will have around 10, 5. Rarely do you can get a 20 PSI. Okay? So with those limitations, then it means that when you're using a concentrator, you might not meet all the settings that you require to meet for the patient. Okay? So you might not be able to meet some of the FiO2s and some of the pressure that the patient might require. So our most recommended sources, since you have the two already, would be wherever possible and highly recommended, you use the wall source or the oxygen cylinders. Okay, so as you train your colleagues, just let them know, because most of the other Cpap systems use concentrators, most people tend to think that even this system needs a concentrator. So please do let them know that this is a different system that needs higher pressures for it to function. So it's a high flow system, okay, as you're going to see. Okay. Okay, in your oxygen source, so there's the cylinder or the source, then there's the flow meter. Okay, so for these flow meters, most of them or almost all of them will always come with a humidifier bottle. Yeah. So our recommendation is that you remove this humidifier bottle from the source. Okay. The reason why you want to remove this humidifier from the source is because you're already going to have humidification within the system. And also, most of these humidifier bottles have a lot of leakages. And within this system, the moment you have a leakage at any point, then it doesn't function well. Or it might not function well, or it might not function at all. So you always don't want any point that there's a leakage of the gases that are going in. So you want to minimize that as much as possible. Okay? When you remove the humidifier bottle, what you're going to have now something like this, yeah? So within the pack, you'll have two adapters, okay? So we have the green adapter, and then we have a white, kind of transparent adapter, okay? You try which one is going to fit. For this system, for example, the green one fits. If the green one doesn't fit, then you try the other one. Just remember that the other one comes with a rubber ring to prevent any leakages from that particular point, okay? The green one doesn't require rubber ring most of the times because it fits on well. Okay? So that's what is going to now fit to your source. What you're going to have the setup is this setup. We don't want a setup where this is here and then you're trying to fix the tubing from the humidifier. Okay? So. Then and from that point on, you're going to have your oxygen tube. When you do the fitting, always make sure that it fits on tightly. Okay? Just remember this always. Any leakage leads to non-functionality or no functionality of the device. So you always want everything to fit on tightly. Okay. Then after that, you come to the blender. Okay? So this is a very innovative part of the device. This is the part of the device that enables us to blend without the functionality of electricity. So we're going to go back to some physics. Okay? Very simple physics. Usually physics are plus 8 from 1. C is a juice and sour. So examples are plus 8, okay? So what is happening is this, yeah? You have a very high pressurized oxygen source. Okay, so let's say this will be, if it is full, most of the time it's like 1,000 psi. Okay? So that thing of it is a very high pressurized source. It comes through this tube. Okay? Then from this tubing, it goes into this nozzle. Okay? This part here. Okay? So this nozzle is a reduced radius compared to this tube. Okay? So physics inasema reduce what happens again? The pressure increases. Yeah? Here they have plus 8 hapo. Plus 6, 7, 8. Still. But the pressure increases, yeah? So the velocity becomes very high. So this is something that is moving at a very high speed. Okay? So when it comes in here, it's a restricted area. Yeah? So with that kind of restriction, what it's trying to do is trying to escape. Okay? But remember, in physics also we say when a liquid, so either gas or a fluid, flows at a very high velocity within a space, what does it do as it moves? It introduces the pressure within that sound. So once the pressure is reduced, what happens is that now you have a lower pressure zone, and then the outside part of it will become a higher pressure zone. Okay? In physics, anybody have an idea? Gases can only flow in one direction. Which direction do gases flow? From what zone to what zone? That's physics we what was it? So Africa class 7. So Apple class 7 and 6. So if I have two zones, one is a low pressure zone, the other one is a high pressure zone. Where will the gases flow towards? From which zone to which zone? High to low. Okay? So the laws of physics dictate that there's no way the gases that are moving in the low pressure zone are going to be able to flow in the opposite direction. Okay? So that's what happens in this blender. Okay? So inside this blender, because of the high velocity of the gases that are coming in, it's going to be a low pressure zone inside. And then outside is going to be a high pressure zone. So the gases from the outside will only be able to flow into the blender as it escapes on this end. Remember, it comes in, it's going very high. So it goes very high, creates a low pressure zone, and then it moves outside. So that is its exit. Because when it tries to move out, it realizes that it cannot move out because of the laws of physics. Okay? So it only requires that the outside gases come in and then they escape. Okay? So that's how the blending eventually happens. Okay? So when you hear the hissing sound, you're going to hear the hissing sound within the system. It doesn't mean in no way, according to physics, that the gas from this source is escaping the outside environment. It's actually the outside, the ambient air within this particular device being sucked in and escaping towards the end of the device. Tumeelewana? Okay? So sometimes when you train some people, they tell you that gases will escape from our because they hear that sound. It's going to be a sound, it's a blending sound. Okay? So what is happening is the laws of physics will never allow the gas that is flowing at a very high velocity to get out. It's only going to be able to suck whatever it can suck from the ambient environment into it. Okay? So, you see these holes here? They are not magnetic, okay? They are not to make the blender look more rich, okay? These holes here help with that mechanism of blending to determine how much oxygen is being sucked in or how much not is sucked, okay? So if you look inside this blender, there are two nozzles, yeah? There's the receiving nozzle and then there's the exit nozzle, okay? Right now, I've opened the blender to all the way out. So when you open it all the way out, you have this oxygen scale here. Okay? So when you open this, first of all remove the nut, make it loose. Then now just rotate this part of it. And open it all the way out until the indicator inside here comes to 30%. Okay? So when that happens, you can realize that the distance between these two nozzles is very wide. Okay? It widens. Yeah? So that means that more of the ambient air will be sucked in to mix with the gases that are going in. So that is how you dilute the concentration of the oxygen from this source. We all know why that needs to happen. Okay? So oxygen is a drug. And it's harmful for, especially for premature babies, it's very harmful. Okay? Now science is very clear about that. It will provide eye problems, ROP, without brain damages and without lung damages. Okay? So you want to reduce the concentration of these always to the lowest concentration when possible. Okay? So when you open this all the way out, what it means is that what you are getting from the exit will be around 30% oxygen concentration. So you will have reduced the 100% to 30%. Now let's go ahead and try and close it. Just go back until your indicator here goes to 100%. Close it all the way. So this is the indicator. See, I tried it here. This is the indicator. So when I'm at 100%, now go back and look at the nozzles here. What has happened to the nozzles? They close up. Okay? So what that means is that whatever is coming from this source, all is going directly out. So you're providing 100%, so there is no blending that is happening. Okay. So, according to the Kenyan guidelines, you should not do that when using a bubble Cpap system. So this is a high flow system. When using this high flow system, there is no time that we should find your blenders closed down. Okay? So your blenders, actually the maximum that your blenders should go to will be around 60%. Okay? You can move towards 70%, but that is a very critical decision to be made around that. Okay? So what we're doing here is, at no given time, do we want our neonates to be receiving 100% oxygen. Okay? So the recommended is up to 60. You can move to 70, but that is a lot of clinical decision making. Okay? When you're moving past that, now Cpap is failing, and there's Cpap failure. Okay? It doesn't mean that every baby you put on the system is going to respond to the system. Kama treatment ingine hawatasikios. Kuna ile treatment unapatia mgonjwa inakata. So you can always start with an antibiotics, you give the patient the antibiotics, they don't respond to it, you need to go a little bit higher, then you go to your lab test, then you find out you're dealing with a MDR case, then you figure out how you're going to manage the MDR case. So Cpap is the same. There's going to be some failures within the patients who are going to be started. Okay. Up to the blender system, are we clear on how it works and what needs to be done? Okay. So now this nozzle comes through, and it should be tight as well. Okay. So this is what you have. So imagine this. Let's say you start at whatever, 30, 50 or whatever. What happens is that you have this oxygen source coming in, it's sucking in the ambient air. The ambient air is not clean, especially for the neonate. Whatever we breathe in right now, for the neonate it might be harmful because you see the construction and there might be construction going on, so there's the dust. That is, you can't see them. There are dust particles, there are microbes, viruses, bacteria that might be floating around. Okay? So what we want to do, we want to still make sure that the neonate receives safe levels of gases. Okay? So that's why you want to do what? You want to filter whatever is coming. So the filter becomes the immediate next after the blender. The filter only goes in one way. So that's the way that it's going to. Okay? Our filter is unique because Okay? So this is just a summary. So this is just a summary of what I was talking about regarding the blender. Then we go to the filter. So the filter is unique in that it's a reusable filter. Okay? So reusability doesn't mean that this is reusable as it is. Okay? What it means is that you can open it up and get rid of the filter disc that is inside. So what happens is that most of the times you have these filters, but they are locked up. Okay? So you will use this as a filter, then discard the entire thing after use. But now, because we want to be in a more sustainable environment, what we have here is a reusable filter. So you need to open it up. To open it up, hold this, and then when you become a skill, I want you to pull them down. Come up on the opposite directions. So just pull that and then it will open up. Okay? When it opens up, you have this white filter disc. Okay? So this is the disposable part of this filter. Okay? So this disc has to be exchanged every 24 hours. Okay? Usikizane. After every 24 hours, you need to change this. When this one turns color, to come up blackish, brownish, kuwa white, you need again to change it. Hata kama 24 hours ikifika, you need to change it. When you're changing the device from one patient to the next patient, also you need to change it. Okay. So those three conditions have always to be met. These other parts are reusable. Reusability means that you need to reprocess them, then you can reuse them. Okay? So the other parts are three parts. So you have two of the plastic holdings, and then you have the ring. Ring when Material rings are some of the devices that we have. Why? Why do you use these rings? Yeah, so to prevent leakage and provide a tight seal, okay? So what you have here is, if you look at this, there are two, the housings, there are two. One imeandikwa insert the filter disc here. Okay? So that's where the filter disc comes and rests. Okay? If you try the other way, it doesn't fit. Okay? So it fits there. The ring comes to the second part, and the second part has a grooving on it. Okay? So you want it to land in that particular grooving. Okay? Then you hold this, that comes on top, then gently, finya tu gently kwa usisukume tu mara moja. Just gently first, so that the ring goes, isikuwe na any kinking, kuwe imeenda straight up. Then we want you to press these 3 points. Make sure that you press them hard, okay? You sikia katli, unanijua sikia hapa the point, yeah? But just make sure that you press them hard, okay? After you press them hard, try to move it, it sticks, okay? So that's how the filter disc is assembled, okay? So the filter disc comes through. So tumefika hapo. Okay. After kufika hapo kuna kitu kinaitwa rotator. Okay? So the rotator is like a small gadget. Iko mwisho ya okay? So the rotator is, it's as its name, it rotates. Okay? So one end of it rotates within. So what happens is that the rotator comes just immediately after the filter. So one end, the remaining end of it will rotate as the other one does it. Okay? So the reason why you need the rotator is that as this system now becomes independent from the proceeding system. And that helps with adjusting everything within the system. If you don't have the rotator, you're going to have a lot of hard time trying to adjust the proceeding side of the system, and you're going to see how that happens. Okay? So or we can demonstrate what happens, okay? So this is what happens. So once you have this tubing here, you will always want to adjust this part without interfering with this part, okay? If this part was all held up, then you couldn't be able to adjust this part. And now you see when you have this rotator here, then this one now, let's say I want to adjust this part, then I can do it. Without this one, also moving. So I can make my adjustments without interfering with this end of the device. Okay? That's why you need the rotator. Okay.
There's no leakage there.
No, we are still continuing. So there's no leakage here. It's rotating without leakages. Okay, the mechanism of rotating doesn't, it's same. It's just rotating in a way that there's no leakage in there. Okay? Then the next part you come to is now the humidifier, which is the blue tube. Okay. So from the humidifier tubing you go to the humidifier itself. So remember your gases are coming in, you blend them, you filter them. Now you want the humidification to happen before it goes to the patient, because you don't want to provide dry gases. Okay? So we know that dry gases are very harmful to the airway of neonates, especially prematures whose airways sometimes are not even developed. So you'll have a lot of thick mucus develop, and also just the drying effect of the airway that will provide some sort of injury. So you want to do the humidification. So let's look at our humidifier board. Yeah? So our humidifier board has two lines. Okay? So there's the first line, which is the refill line, and there's the second line, fill to here. Okay? When you want to start at the beginning of using the device, you want your fluid level to be at this point. Okay? When it goes down below this second line, you always want to refill back to there. The reason being, you see, the humidification only happens through this tubing. Okay, this tubing drives in the gases. Okay, as it drives in the gases, the humidification happens. Then the air flows. So when you are below this line, you can see that the tubing is now almost low within the contact. Yeah. So what will happen is again no humidification, the provision of dry gases. So you always want to come back here. Some people ask us, why don't I just fill it up to halfway and then wait? Instead of the hassle of filling it to this line, then you have to wait. The reason again is this system is not, doesn't function well where there's a lot of resistance within the system. So when you put the fluid above this line, the resistance increases above what the engineers envisioned to. So you'll have a lot of resistance within the system. So you don't want to create that resistance, okay? Secondly, when you fill it so much high, the content here will always be bubbling, and you don't want an effect of it going through the breathing tube, okay? So that's why you want to maintain it at that particular level. So please emphasize that as you train. The content in here should always and must always, when possible, be distilled water. Okay? Distilled water. And I think that's the message you want here. Okay? So this one should always be distilled water. Don't add anything to that distilled water. Okay? So then at the top, the lid, you'll have two aspects. So you'll have the inlet and then to the patient. Okay? The blue tubing comes to the inlet, and then the patient tubing now comes to the patient end. Okay? So that's what you're going to have within this part. So this comes in there. Okay? So So we see how the gases are flown. It's the same thing that Chol presented at the beginning. So you have the oxygen source, you have blending, filter, then now you humidify, and then now you go to the patient. So you will have your first patient tubing. Okay. So this is the inspiratory end of the system. Okay. So when the patient now wants to breathe, so you have the inspiratory tubing, but it's open. So you have to find out the mechanism of getting the gases in, and that's where you have the so now you have the nasal props, okay? But they are silicone based, okay? Very gentle to the neurite. So this particular prong comes with different parts, okay? So you have these two parts, they are called the elbows, okay? Then you have this main part. Why we separating it this way is because these are reusable, okay? So during the processing, we don't want it to be hard to process, okay? How do we assemble it? Please emphasize on this, because if you don't, then they're going to have a lot of problems with them, okay? How you want to assemble them? So just let's remove the elbows, okay? So we want to assemble this. So you see, you can let the elbows become a screwing point, yeah? Okay? So we want you to go in as if you're screwing in, yeah? And I want you to do it in such a way that just rotate it as if the same way, but a little bit of force. We want you to screw it until it goes to the very end of that elbow. Okay? Screw it to the end, the very end of it. Okay? Screw it to the very end. Okay? This is very important. If you don't screw it to the very end, what happens is when you put it on the patient, it gets out. Every time you try to adjust things, it gets out. So the way to hold it together, you have to screw it to the very end of that end. Imefika? Imefika mwisho. Okay? Then the second part. Oh. Yeah. Then the second part again, you do the same. Yeah? So the most important, unaona kama iko to the end, yeah? What happens is, when it's not screwed well, unagonga kama DCI. So you see what happens when you don't screw this to the end. What happens is when this system moves, this one just tends to come off. So that's why that mechanism is key. Yeah? Then after screwing to the very end, you align it so that it's aligned well. So you have something like this. Sure. You know. Okay, so you have something on the subsidiary. Okay? So that's what now comes to the first end of the tubing. Okay? So how you want it to go into the patient nares is, you see, downwards. Yeah? Okay? So that's how you want it to follow the anatomy flow of the air. So that's how it's supposed to go. Okay? So you determine how your patient will be positioned, and then that's what makes you determine how this is going to come in. So if my patient is somewhere here, with the head facing this side, then my prongs will be this way. Okay? So that comes to the first end, and And then you need the second tubing for the inspiratory. That's the second end of the tube. Okay. So getting to this point, you have your baby already getting there. Inspiratory needs, and then they'll expire. And now we go to the pressure generation. So our next. Our next part is the pressure, then pressure. Okay? So let's go through the pressure generation. Okay? So the bottle has the bottle itself to this lower part. It only has one line, fill to here. Remember that had two lines, this only has one line. Okay? So fill to here, meaning that your fluid content here must always be this line. Always. Okay? Why must it always be there? It's because, as we see, we have this one, okay? In Nakagama straw. So, this one is calibrated from 4, 5, 6, 7, 8, 9, and 10. Okay? So these numbers represent the pressures of water. So it's 4 centimeters pressures of water, 5, 6, 7, up to 10 centimeters pressures of water. The only way you can determine the correct pressures of water, the calibration, is this is the line. So we're sure that if you are within this line and your tubing is reading 4, then you'll be at 4 centimeters pressures of water. If you are to let this go down, it would mean that you're providing lower pressures of water. If you are to go above this line, it will mean that you're providing higher pressures of water. Okay? So that's what you don't want to happen. So you have this tubing because you have distilled water. Please make sure that the content here also is just distilled water. Okay? When at a point that you must struggle and distilled water kidogo, this can always be clean water. But when the distilled water is available, just make sure both of the tubings are distilled water. Okay. So that is the bottle. Then above the bottle you have the lid and this. Okay. So how does this go up? How is it adjusted? Yeah? So to adjust this probe, this one, you have these arrows. Okay. So these arrows are less than a point. Yeah? So to adjust this thing, what we want you to do, when you use arrows in a point, put your up and squeeze inside. Okay? When you squeeze inside, you unlock the system. So this comes out. Okay? When you want to make adjustment always, you have to squeeze this point. Okay? A little bit higher, it's in the chin side. You squeeze it, then you see this, it is not a men, yeah? They are the ones that lock the system. So when you release them, this one goes in. When you let it go, this one is locked. Okay? So what will happen is, kama mtu ana struggle na hii na just squeeze, these two men zitakuji, so they won't function. Okay? So you want to make sure that you do that particular operation. Okay? How do we read the pressure? The number immediately above, the number visible, that is the pressure. Okay? So like right now, my number immediately above is 5. So that will be my pressure. Okay? So this is how this is. Any question on this? Okay? So whatever the baby is exerting is going against the fluid that is here. Okay? So let's say you are, this one is immersed all the way. It means that the pressure that it's going against is a very high. It's higher. Okay, so it means that they use a lot of force to try to excel against this, because eventually there has to be some of escaping. The gases has to escape out. Okay, because remember what we said, there's no backflow of gases. Okay, so the baby has to generate that pressure. So to generate that pressure, depending on how deep this is, to determine how much they need to generate to go against this. That's it. Push the air. Okay, and that's how the pressure now is generated to have the alveoli open. So a baby who has so you when you require, don't you want to tell me?
So what is happening is we want to open the lungs of the baby. We want to open the alveoli and open the collapsed airway. So for the airways to be open, there must be a pressure. So that pressure should be adequate enough to open the lungs and to open the alveoli and keep the alveoli open. So the deeper you go, the higher you generate pressure. The shallower you go with the one, the less pressure you generate. So take for example, you start the baby on a pressure of say for example you have started a baby on a pressure of 6. And you notice that even after starting pressure of 6, the valve of breathing is still high. Still granting, still lower tail volume growing, still nasal flaring. So the work of breathing is still high. 30 minutes or 1 hour after starting on Cpap, you still see the work of breathing. So it is advisable you escalate. You can go to pressure of 7. So in this way, you are trying to open more alveoli and recruit your alveoli to remain open so that there is more oxygenation. And when there is more oxygenation, then the work of breathing will increase. Yes. If the work of breathing, maybe after 6 hours or maybe after 24 hours, and the work of breathing has reduced, then now you can think about reducing the pressures. But you start reducing the flow, the oxygen concentration before you reduce the pressures. That one we'll do it later. We'll do it practical later. That's the next session.
Okay. So here you see that you apply high concentration, high pressure. That means you can give 10.
No.
4 liters. Start with 4 liters per minute.
4 liters per minute. And then it becomes here we have a with leg.
Yes.
Whereby you see we can give 6. That means there is a pressure that has been created up to this point.
No, there is flow. So currently we are talking about flows. There's the flow of gases. So whatever comes here, what happens here is that we reduce the concentration levels. So when you reduce the concentration levels, then it comes.
There is that positive pressure.
So the positive pressure is always with the device. Yeah, this is only for humidification. So whatever is passing, it only passes here for the function of it, because you don't want to provide the neonate with dry gases. Okay? Once the neonate must first of all meet their need, the oxygenation need. Once they meet that, then they can be able to bring out and provide pressure. Because if the alveoli are not being muted, so it means that the neonate also is not able to properly breathe out. The function is to help with the because remember, think of the balloon concept. So once you blow a balloon, it's easier for you to slow it back the way it needs to be if you don't let it all inflate out. Okay? So that is how we want the unit to be. The unit can only be comfortable if there's always some sort of residual air that remains within the alveoli. If there's not that residual kind of gasket that remains, then it means that the alveoli is completely collapsed. When they completely collapse, they require a lot of effort to try and open them up again. So what you want is like a balloon. You always want it to remain with some gases in it. So it goes back, but it's easy for them to just breathe. The moment you let it go down completely, that's when they have a lot of vacuum breathing. They are really trying hard to make them open up. Yeah. So this is just to maintain that pressure. It's to maintain the pressure so that they are not losing anything from them. So like this is something that is being retained in their alveoli as a residue. So that every time that this is coming in and they're trying to breathe out, they just go back. So they become comfortable when now that particular mechanism is well maintained within the, because the alveoli is equal, that most of them, yeah? So you need most of them to be in that state for the baby to now be as a program, not raise. At the moment, humanity as a lazima kukuwa, but that's why you will see that the work of breathing. It's clear now? Okay. Yeah. So that comes to the other end, and now you have the other tube. Okay? So on this end, this tubing cannot go directly in. Okay? So sijaribu kufanya hivi alafu waeke strapping. Okay? So that's why you have this. It's called the pressure generator connector. Okay? So it comes in and rests within this depression here. So this is just to help hold it here so that it's not moving everywhere. Then that comes there, make sure it's tight, and that now when you are able to connect that. Okay? So to hold this thing together, unaona vile sasa hii inakaa ni kama machupa zenye ziko kwa water. Yeah? So you need these things to be held together. Yeah? So that's why you have the warm-up bracket. Okay? So the warm-up bracket is called a warm-up bracket not because it warms, but because initially, when this was being brought to the market, we wanted it to be in the warm-up. Okay? That theory has changed a little bit because we find out in most environments where you go to, India, maybe mnaweza kuwa na warmer za sadaka, lakini kuna wengine wana warmer, sio? So in most of the places we work in public facilities, you'll find they don't have warmers. Okay? So, but when you have a warmer, you can easily put this on the warmer side. So that's why it's called a warmer bracket. But the main function is to hold the entire system together. So in here you have writings on it. So there's a humidifier, pressure generator. That is to guide you what goes where. Okay? So the humidifier bottle goes in there. Then the pressure generator goes in there. Now you have your bottles held. The other thing that now is floating and goes around is the blender. So also you want the blender to be there in the system, and to achieve that now you have the blender clip. Okay? So the blender clip, unaona hii part hapa side ya the humidifier, so it comes and rests in there. Then what you want to do is you just want to slide this in. So this is our system. Okay? So everything is there now. So remember when we say the flow, you can just repeat this. So what has happened from the beginning when we started? So what is happening is, I have my oxygen source. I come in here, I blend it. After blending it, I filter it. After filtering, I humidify it. Goes to the patient. Based on how the patient is meeting their demand, they are able to exhale. As they try to exhale against these pressures here, the bubbling will happen in this. Okay. Any questions? Nikiwaita moja moja mmoja sisi kosa. Okay. Yes, but the functionality of the device is based on the fact that so we created that next. Okay? So that is how the system is, okay? So we want now to go to the patient part of it. But before we go to the patient part of it, we want to test if your system is something. Okay? So hii system haina button, lazima nimewasha button na naona vitu zina move, so the system is working. So you have
Can company provide so she's asking if company can buy many hats. Which company? Value or PCA? Yeah, for sure, PCA can get as many hats as possible. So that when one is worn out, you can use the other. So she's asking, when can you get these filters for replacement? Or where will you get the filters for replacement? I think a very important question. If filters finish, where are you going to get the filters? So you can buy filters. You can buy from a distributor. We have a distributor in Kenya. By the way, all these parts are manufactured in Kenya. All these bio devices are manufactured in Italy, then exported all over the world, even to Belgium, even to Ukraine. So we have a distributor in Kenya. So we can link the hospital to a distributor in Kenya. And then once you see that your consumables are finishing, or this one are wearing out, or the axis becoming loose, or the breathing tubes are getting finished. So the hospital procurement or the hospital supply should be in touch with the distributor. So if these things are finishing, call the distributor. We need filter list. Yeah. We need filters, they are finishing. We need anything else that you need from distributor, they will be able to supply. So that's where you can get the filters. Yeah, of course they can finish, because if they're high volume unit, yeah, filters can finish. Another question? So, from here, we will now do hands-on sessions. So in the hands-on session will be you practicing on the device, on how to assemble, how to disassemble, how to monitor, and how to process the device. So 4 things. We'll be doing practicals on 4 things. Assembly of the device, disassembly of the device, monitoring of the device and the patient, and then reprocessing the device. So So we were told that we have to finish by 12, right? It is 12:40. So I request we may need another 1 hour for you to practice this. Because everything we have been saying is theory and a bit of hands-on activities. So we need your hands now to practice this, how to use this device. So should we take 1 hour after it's 12:40? Should we come back at 2 or we continue now and finish at 2? What do you suggest? Who is managing our breaks? Tea break, lunch break. You will see
system now. So when we initiate so first of all, we start from
people are teaching people who are not yet
okay, so when to connect this system? So when to maybe connect it to our patient. So first of all, we make sure that we have all the requirements. We assemble from our source of oxygen. We have the cylinder here. So the equipment we are going to connect is this bio-piper.
So bubble Cpap.
5 bubble Cpap. So we'll start assembling our equipment, right? So we'll start. We'll ensure that we have all with the tubing. Case here. So we have the source here. This is our cylinder. So and we have the tubing. So we connected this from our source, right? So we can start anywhere, whichever, so long as we end up making our system work. So from our case, we have what do you call this? Adapter, right? So it's oxygen source adapter. So let's connect it here and make sure it's fitting well. Right, so the oxygen tubing connected to our source of oxygen. Our case is a cylinder. Make it fits well. So from this end, so let's assemble this first. Pressure generator, we assemble first. So and in place we should be. Okay, here is a pressure generator holder. So let's assemble for the humidifier. Sit here. So we get what do you call this? The tubing, right?
Humidifier tube.
So these are humidifier tubing. You know the difference? These are this white. So from this end, this is a humidifier, right? So this is the inlet. So our inlet, we have, let's go with this for the patient. So this we choose it based on the patient. So let's case maybe it's implant, not implant. Let's see this. Fix this first. come to that. What do you call this? The blender. Okay, we have the blender here. We can fit it fast. So in this case, we have, let's assemble the filter. So follow the instructions. So now you put the filter first, then the rubber already is in its position. Fit it well. So here we have the tubing. What do you call it? So what's this? Rotate, right? So we'll fit is when to connect our oxygen source from this tubing to our blender. Make sure it fits well. So we connect the humidifier tubing. Yes, here. It's the here, right? Then we fit. This goes to our patient. These are distilled water. So that's water. Close it tightly. So before you connect it to your patient, ensure that all the nail closed, well fitting. So here for you to adjust, you can adjust based on the amount of pressure you need. So we have already connected our tubing well, but we're going to source for our patient. So assuming we have our patient here, so I'll adjust. So to the that's around 4 meters. blood. So the pressure here we are at 6.
Why is it not about?
Where we are?
We are at 4.
Why is it not about? So these are some of the challenges we face. So you have to look for where the leak is. Where is the leak coming out from? So the leak test is successful.
We are not now.
We are holding. Sometimes the pressure coming out from maybe the pressure is less, that's why. Yeah, go ahead. So the leak test, once the leak test is successful, then we can come to patient application.
Our system is the next thing is the patient.
You have just tested your device is working.
The device is working. So for our case, there's these devices. You have to use it as you connect it to your patient. It's called what? Mouse touch, right? So we have mouse touch and we have, how do you call this? Soft loop filters. Fasters, right? So you start with this, you connect here. So that should be to both sides. After connecting it, so you stick this to your patient. Mouse touch. So make sure it fits there. That's it. So, but that's it. So we need to put it in our patient. So this is based on the size of your patient, right? So yeah, in a discussing it. So we have the heart. So based on the different charts, our patients have, right? Session recent feet. So in and feet. So we go to the next step, we get our safety pins. We did horizontally. Let's read to our patient only. Mother is so we prevent this as much as possible.
So you see, the pin is not.
But make sure you do this out of your patient. The other one. You secure this. After securing it, you run your system now. So you adjust your oxygen based on the demand. So in this case, I have started my at 4 liters. So this part of the pressure is the amount of oxygen you're delivering to your patient. So next thing we are testing two parameters about the amplified pressure and then percentage of oxygen. So based on the oxygen level here. I think it's in it's continuous. It's flowing systematically.
Okay, any question?
So we are around below 40.
So the guideline recommends that we will start at about 6 and evaluate of 50. What do you say? No, pressure of 6, evaluate of 50. That's opinion guideline. For the lead test, you can do pressure of 5. then I will do a pressure, a big test. But when you are now looking on a baby, you can do pressure of 6, and then a variety of this. So you can clap for him. So yeah, that's how the practice is. So this is assembly. Then someone can come and do this assembly. So come and demonstrate how to disassemble the device. Come on, before we disassemble, let someone come and do monitoring so that we disassemble after monitoring. She was prepared for disassembly only. Monitoring. I can project it here and then you just follow the steps. Monitoring. We need one person. One person to stand up and come here. You can do one time. So
monitoring, you monitor what the device in the patient. So you deal with the device. So you check first. So you first ensure that the fluid that the water is filled to the right level, what the purifier, and the pressure generator chamber. And then you also check for leakage. Either from the kilometer all the way to the system, what we do, the leak test. So you ensure that this, you ensure that there is no leakage from the flows. You ensure that it is fitting well. You ensure that the tubing from the kilometer fits well to the blender, and the blender fits well to the filter, both this side, the filter, the rotator, this tubing, then humidifier tubing fits well both to the filter and the chamber, and you ensure so this tubing to the patient and this one to the pressure chamber fits well. And you also ensure that the pump fits well to the patient. So that is, these are the areas where leakage can occur. And then you also monitor the system. The other thing is you should ensure that your oxygen is adequate. So you check whether if you are using a cylinder, whether it has oxygen enough to support the pressure. And then to the patient now, you check the position of the mustard. It should be just a few 2 to 3 millimeters from the nasal septum, so that it does not cause injury. To the patient, you should also check. And then the other things is prevention of nasal injuries. That is The bronze should not, there should be no whitening at the nostrils, on the upper part of the nails. That shows that there's some pressure there. And then you should ensure that there's no moisture around the nasal region. And you can also apply some ointment to prevent injuries. And then sanctioning gently, but only when necessary. And massage. Massage. And then you monitor saturation. For the patient, you say you can monitor hourly. And you also assess the work of breathing so that you can get feedback on whether the baby is responding to the Cpap. Oh, and then I forgot the reading assessment. Then reading assessment, we say it is based on time. After 24 hours, you can decide to wean. And then how the patient is responding, you assess whether our breathing has improved and oxygen saturation. Then now you can plan to wean off.
Yeah, very good. Yeah, like the way she's saying, if you follow how the system is, it will be very easy for you to monitor. So monitor if you have enough oxygen. If the tank is full, right now our tank is reading 0. So monitor if the tank has oxygen. Then come here, just follow. When the oxygen comes in, it goes into the blender, right? So make sure your settings are appropriate. Then from the blender it comes to the filter. So monitoring filter is making sure that you change your filter every 24 hours, or when you change from patient to patient, or when you see the filter is discolored, it has changed color. So remove the filter and put a new one. Then continue following with the humidifier. What do we monitor in the humidifier? Is making sure our humidifier is filled up to fill line. So the water levels are good. Then it goes to the patient. So before you do patient monitoring, come back again to the device. So what should you monitor here? Water level as well. So water level should be up to this fill line. Then if it is less than this, you refill. After 24 hours, you discard. Same thing to the filter. After 24 hours, you discard. If the water levels are less, make sure your pressure is appropriately set to the desired pressure you want. If you have set it at 5, make sure it is at 5. If it is at 6, make sure it is at 6. So this is the device monitoring. So bubbling, it should be appropriately bubbling, continuous bubbling. It should not be intermittent. It should not be vigorous. It should continuously bubble. So this is the device monitoring. Then coming to the patient monitoring. So patient monitoring is also connected to the device monitoring. So work of breathing. What is going on with work of breathing? Is the patient still having work of breathing? Nasal flaring, lower chest volume drawing, grunting, intercostal recession. Is your baby still having severe work of breathing? Okay. If the work of breathing is high, you come back to the device and check if you are really having appropriate setting for the device. If your pressures are good. So if you are at 6, you may consider going to 7. Because what we need here is the pressure to open the alveoli, open the collapsed airways, recruit more alveoli, and keep the alveoli open. That's the whole point. So when the alveoli is open, when more alveoli are recruited, when the airway is patterned, this is when you can meet the inspiratory demands of the baby. Okay? So while breathing okay, then check your pulse, your oxygen saturations. Are your oxygen saturations above 90? If they are not above 90, what do you monitor here again? You come and check if your FiO2 are appropriately set. If you are at appropriate FiO2. If they are not at appropriate FiO2, set again your FiO2. And then continuously checking the baby. So this is how you monitor the device and monitor the baby. Then she also mentioned some very important point about weaning. So when you want to wean, assess readiness for weaning. Is the work of breathing improved? Are oxygen saturations improved? Is the baby stable enough to wean off to Cpap? So assess if the baby is ready to be weaned Cpap. Then she also mentioned other important parts to monitor. Prevention of nasal injuries. So be sure the secretions are not here. So if you see any secretions in the nerves, suction wherever you can see. Make sure this area is dry. Make sure you massage the nose. So make sure there is appropriate distance between the columella and the nasal fronts. At least how many millimeters? How many centimeters? 2 to 3. Yes. So make sure there is appropriate distance. So in that way, you are able to prevent nasal injuries. Apply some saline drops in both nerves to keep the nerves moist. So this is monitoring the device, monitoring the patient. Then later on we'll talk about other things you should also look out in the patient. So because it's not the device alone treating the baby, it is you treating the baby. So make sure you take care of the baby as a whole. If the baby needs antibiotics, put on antibiotics. If the baby needs feeding, let the baby feed. I think we did mention how to insert NG tube for this baby. So a baby on Cpap, do you put NG tube or OG tube? OGT or NG? Huh? OGT. Why not NGT? So this is a closed system. So if it is a closed system, you don't need an NG tube to go into the nerves again. So it will create a leak. It will create a leak. So make sure you put an OGT. So if you put NGT, the radius of the nerves will be white. So if the radius of the nerves is white, then you will create a leak. So it means the bubbling will not be the type of bubbling we want with these babies. So put the OGT for feeding. What else do you put OGT for? Put the OGT for feeding and food for? To decompress the stomach. Because some of the air is going to the lung, some of it is going to the stomach. So if you don't put OGT, the stomach will be distended. So once the stomach is distended, it compromises muscles of breathing muscles. Yeah, it will compromise the diaphragm. So the baby will not be breathing properly. So put OGT, it will decompress the stomach. Then how do you feed babies on OGT? how do you feed them now after putting OGT? OGT? You just feed them the way other babies on OGT are fed, or another baby on OGT is fed. How do you feed babies on nasogastric tube or oral gastric tube? You feed 3 hours. Okay. Oh, it depends on the needs of the baby. You can feed every 2 hours.